Thanks for joining us on Not Boring CEs, where we don't think you should be bored to death while getting your continuing ed. Keep listening here, then hop over to notboringces.com to get all your online CE credits. All right, y'all, let's get to learning. Emily Foxen-Craft, PhD, is a pediatric pain psychologist with over 7 years of experience and the enthusiastic owner of Pediatric Pain and Behavioral Health. She provides treatment to children, teens, and young adults with chronic pain, chronic illness, and anxiety. Common concerns include headaches, digestive symptoms, sports injuries, and stress, but she always personalizes care to help the individual and family learn to manage their symptoms, improve functioning, and develop resilience for life. Dr. Foxen-Craft is a licensed psychologist in the state of Michigan, but is also authorized to provide interjurisdictional telehealth to 40 states through SIPACT. Prior to launching Pediatric Pain and Behavioral Health, she helped found the University of Michigan's Pediatric Chronic Pain Program as a postdoctoral fellow, and then as a faculty member in the departments of pediatrics and anesthesiology. She continues to conduct and publish research and to educate psychology trainees as well as pediatricians in pediatric pain management. Welcome, Emily. Welcome back to Not Boring CEs. I'm your host, Allison Puryear, and I am here with Emily Foxen-Craft, and we are going to be talking about the psychology of headaches. This is something I know basically nothing about. So I'm very excited to learn from you. I've appreciated your other CEs with us around pain. It is all new territory for me, and I suspect for many other people learning. So thanks for being here.
Thanks for having me. It's fun to chat about. Hopefully I'm not a pain, but I'm excited to be able to give some ideas that might be able to help clients, clinicians, family members, etc.
Awesome. Great. Well, let's kind of just start with headaches in general. Can we talk some about prevalence and what a headache is even, because I don't know if I'm accurate in my assumption about what a headache is.
Yeah, the interesting thing about headaches is that most of us have experience with one. I read a stat that from a lit review that had suggested that upwards almost 16% of people in the world at any given moment are experiencing a headache. So it is a pretty universal phenomenon, and they look at meta-analyses, and they suggest that upwards of 50% of people have some sort of headache condition, which I think is astronomical, but it just shows the commonality of it. And I think that, first of all, as clinicians, being aware that many of the people that we're seeing might be dealing with this, and they may or may not have spoken about it because it is so commonplace, but also the fact that us as clinicians may have our own experiences with it and may project those experiences or those expectations around our experience with headaches onto what somebody else might be experiencing. So I think that is a really interesting, the commonality of it, I think, highlights the need to try to help, but also that we're all kind of in this together in some interesting ways.
Yeah, which does great things for empathy, but also because of that projection piece can be dangerous clinically, because we can project and not fully hear the client's experience because our own is blocking us from that.
Exactly. So taking the time to think and learn and grow, this field is always evolving. So there's always new things to read about and learn about to enhance your own self-care and maybe care for the people around you.
Yeah. So can we talk about what a headache is versus like a migraine versus something we might think is a headache but isn't?
Absolutely. So this is a whole field, and people are specialists in determining this. So I'll try to give some overviews. But, as we know, physicians and neurologists are probably the people making these diagnoses independent, thoroughly. And usually it's through a combination of a thorough history taking and a neurological exam. So you should not be making a diagnosis to somebody, but being aware of the common categories might help you guide somebody that you're working with to asking the right questions and getting the right kind of care, and then working with them to try to provide all the comprehensive care that they may need or benefit from. But broadly speaking, headaches and all the diagnoses are included in something called the International Classification on Headache Disorders. It's kind of like neurologists' DSM. And so it does go through all of these different categories, and it is searchable online. So you can kind of see a lot more about the different categories that may be going on. Like you may have heard if we listen to the pain talk, there's two overall categories of headaches. One is called primary headache and one is called secondary headache. And it has to kind of it has to do with, is the headache the main diagnosis or is the headache a result of something else? So if a headache is the result of something else, we call it a secondary headache. That could be something like pressure in the brain or something inside the brain causing the symptoms. And a primary headache is the main disease. Under that, there are two categories I think most of us are familiar with kind of hearing about or maybe thinking that we understand. One is kind of called the classic headache or the tension headache or tension type headache. And then there's migraine, which has a lot of subcategories within it. So both of those have different kind of patterns, and clinicians and healthcare providers will kind of go through those patterns and kind of determine, does it fit more in one of those categories? But overall, a tension type headache has kind of a pattern in how patients report how it feels, often like a band around their head. And there may be other patterns to it, to duration and intensity. A migraine is not just an intense headache. It has features that include how long and how frequent, how responsive it is to certain positions or movement, and then also being accompanied by other symptoms like nausea, sensitivity to light or sound, with a term for that is photophobia or phonophobia. And so if it's kind of fitting more with those features, the individual might qualify for a diagnosis of migraine. And then again, they have different presentations that have to do with where in the brain it might be affected, or might, the pathophysiology of headache might be occurring, and so it might produce different symptoms. So if it occurs more in the brainstem, you might have more dizziness and other kinds of symptoms. If it's happening in different other parts of the brain, it might affect more vision. And so sometimes there's also an aura accompanied with migraine. That can actually happen before, during, or after the kind of onset of the headache symptoms or the headache pain itself. So headache is kind of a broad category that includes a lot of different diagnoses, a lot of different reasons. But most commonly, one of the main features is the headache pain. And then differentiating a headache from a migraine will have to do with some of those unique patterns of migraine. Of course, migraine kind of also includes some categories where headache pain is not the main feature. So there's things like abdominal migraine or cyclical vomiting syndrome, but those are kind of niche diagnoses that, unless you're working especially with children too, may not be as common amongst the people that you're seeing.
Mm-hmm. I'm thinking about WebMD and the danger therein, but how that, like, Googling symptoms is probably one of the first places we look when we're not feeling good or our kids not feeling good or whoever we might be caretaking. While there are, I definitely remember at one point, maybe in like grad school, the internet was new, WebMD was new, maybe it was after grad school, but I was pretty young, and looking things up and it being like, you may have a brain tumor, and being like, oh my God. So I think in this day and age, we know better than to rely on WebMD, but I think it can still kind of get in our head sometimes. And it feels very scary when it might be something to do with the brain. What are some things that are characteristic of either like a regular kind of headache or migraine that may seem concerning? And like, now you've got brain cancer kind of a way, but are just a symptom of headaches, and it could just be that?
Great question. So first of all, always important for ourselves, for the people around us, and patients to get checked out by a qualified medical provider to really check that out. And just so you know what they're doing when they're doing their evaluation, so whether it's a primary care or a specialist, in addition to the history taking, they're doing a neurological exam, and what they're testing is common nerves in the brain and how they operate in the body. And if they see something not working properly, that is an indication for them that something may be present in the brain, like causing pressure, for instance, that shouldn't be there, like a tumor. And then they may refer on for additional tests and scanning and imaging. But if they see that, the presentation is perfectly fitting with migraine and your neuro exam or your patient's neuro exam is perfect, they may not make you undergo that expensive, costly, distressing, potentially with, its own effects test. So they're, getting checked out is the best way to kind of be really sure. But if you're reading WebMD and you're like, oh, it might be a brain tumor, of course, recognize they have to say that. They have to kind of cover their bases and just take a deep breath and ask yourself, is this something that's been going on for a long time? If it's sudden and new for you, then definitely maybe it's important to get checked out, important to get checked out regardless if you haven't already. But if it's something that's been going on for a long time, unlikely that something just suddenly changed with you, that you suddenly have a brain tumor when you didn't before. Again, never say never, but always get checked out. But just take the stress down and then call your doctor. Secondly, there are, like you said, there are kind of sometimes scary and concerning symptoms, especially, I work with children. So especially when parents see these symptoms in their own children, it could be really scary. And so there are some concerns, like with some presentations of migraine, that may cause somebody to lose functioning or get all these tingly symptoms on a side of their body that can maybe make them think that they're getting a stroke, which is very scary. And that's a hemiplegic migraine, which is, it's rare, it's severe, and we do want to treat it, but it's not the same thing. If you are vomiting a lot with your migraine, that can be really scary, but could be a classic migraine symptom. And then sometimes the visual aura is really scary even too. So visual aura can be things that are, positive things that you add to your vision, like the sparkles and waves and things like that. But also a visual aura can be a negative, a lack of vision. So blurring of vision or a blocking of part of your field of vision. So a neurologist or a physician will look at your vision and take your history if you're not having a migraine in the office and ask you more about, well, could you block one eye and could you see, or was it the sides of your eyes where you couldn't see, and get a lot more detail to be able to determine if it's mapping onto something pressing on your optic nerve, or if it is a symptom of migraine coming from your occipital cortex or something like that. So they will be kind of looking at some of those details.
Are there times of life where these, like, either regular headaches or migraines are more prevalent?
We can blame puberty. That's a fun one.
Yeah.
Any time in life where your hormones are changing, that is a time of changes in onset. I also things like injuries or illnesses can provoke migraines. So sometimes people who maybe got occasional headaches or migraines experience an illness or something like a concussion. And then all of us, they kind of recover from that, but the headaches then are there and present and longer lasting. So sometimes there are these events that seem to trigger things, especially in people maybe who have a genetic vulnerability, or maybe had somewhat of a little bit of the history before, and then it just becomes a lot worse after that inciting event. Life changes, changes and major changes in routine, our changes to our environment, things like exposure to allergens and things like that could certainly precipitate changes for somebody.
And is that migraines and headaches, or primarily migraines, those kinds of changes?
Sure, great question. We see a change in migraine, especially around puberty. So that's one thing that we often see is, interestingly enough, the rates of headache are pretty parallel in males and females, but kind of around puberty, migraines really kind of take off in females, unfortunately. Doesn't mean men can't have them, but it just tends to become more common, and the rates kind of skyrocket in adolescence. So that's one thing to kind of be on the lookout for. It's interesting when you kind of look at these studies, sometimes the studies will be really narrow in their scope of who they're including in a study to track some of these trajectories or some of these mechanisms. Sometimes they're very broad and they include a lot of different diagnoses in them. So sometimes it's difficult to infer exactly what's what. But this field has also been, because the diagnoses are relatively clear cut and they have so much rigor around the diagnoses, there's an excellent field of research in this area.
Wonderful. Yeah, that's kind of, I feel like in our psychology field, there isn't always as much data to go on. So this crossover with the medical community can, I'm glad they've got more data. And then selfish question, because I had migraines during puberty, but not once it had really set in. They just went away. Does that mean I'm more likely to have it once I hit perimenopause or menopause? Is it an increased likelihood?
That's a great question. To be honest, I don't know if I know that on the top of my head. Maybe it's something to kind of be aware of. Shifting hormones could change, but a lot of people do have reported to us. Again, I worked in a pediatric clinic, so I got to witness children, growing up into early adulthood, or sometimes the parents themselves describing their own trajectories. And often people would kind of naturally outgrow their headaches. And we didn't have a really good way of telling who that would happen for and who it wouldn't. Necessarily. And so we always just said, let's treat what we have now and hope for the best. And if we reach a period where we're feeling a lot better and we're on our treatment, we see if that's sustained for a while, then we can start tapering down on the treatments and see if you're still feeling better and if you've truly kind of quote unquote outgrown your headaches.
Yeah, awesome. And I'm thinking about other another thing I don't think we mentioned that can trigger them might be medications as well, like changing medications or getting on medications. Are there any classes of medication that are more likely to cause either headaches or migraines that you know of?
That's a great question. One of the interesting areas that you might hear people discussing is a concept called medication overuse headache, which is a little controversial in the field. People have different opinions on it, but what it's describing is this concept of kind of a vicious cycle where if you are experiencing many headaches or migraine episodes, to try to treat it, you might be taking medications like over-the-counter or prescription medications to try to treat the headache itself, things like Tylenol, ibuprofen, or again, prescription medications. But this theory posits, or this, this idea is that the more you use it, kind of the more your body either kind of learns to tolerate it in a way or learns to adapt to it in some capacity. And then that promotes more resistant and more headache frequency as well. So that is one area to kind of be on the lookout for. And if you are meeting with a physician or your therapist, kind of be open and honest about how you're treating it day to day. And if you're a therapist, be on the lookout for things like, oh, I take ibuprofen or Tylenol 5 times a week every day just to get through. And then maybe consider checking in with their medical provider just to see if that's something that they've heard about and what advice they have already shared. And then that's something that you as a clinician could kind of reinforce a message that's being shared and help them with a plan. Because if that is truly something that's happening for somebody, it can be very difficult and scary to make that change.
Yeah,
and make
absolutely.
recommended change. In terms of other prescription medications that result in headache, that's not my particular area of expertise. And again, I work mostly with children, so I'm a little less familiar with some of the common medications that adults may take, like things related to heart health. So I would defer to experts in that area, but I would be happy to look some things up and share it in some capacity in the future or for notes on this presentation.
Got it. Awesome. Thank you. So I want to talk about how to communicate about pain with clients and how to facilitate or empower them to have conversations with providers around headaches.
Yes. That's a great kind of a common thing that people struggle with. And I think a great place where therapists can help with this challenge of living with headaches, because we are great at communicating and we're great at personalizing things and really empowering and coaching individuals, even if it's something that we're not as familiar with. So I think some places to think about is just starting to brainstorm for yourself, where might the individual that you're working with have some challenges when it comes to communication about their pain? Is it understanding it for themselves and what they're going through and all the different factors? But thinking about the people and all their different ecosystems. So maybe it's a partner or a spouse who's, maybe frustrated that they are lying on the couch at the end of the day at work. Or maybe it's their own children who are wondering why mom is saying that she has a headache and is lying in bed in the dark. But certainly if they're a child, being able to share about their experience and what they're actually going through with an adult can be a difficult thing, because trying to abstract something like pain, it can be, it seems obvious, but it can be challenging to be able to communicate that. But then beyond the immediate family, thinking about school workplaces. Sometimes, again, we all bring in our experiences and expectations. And so when other people are doing that in those places, it can be really challenging. So they have done studies on things like school nurses or HR representatives, and have identified some challenges in expectations and barriers to getting accommodations in those different environments. So that might be an area. And of course, thinking about the healthcare provider that they're seeing. Hopefully they have a really positive relationship. And so things to thinking about are, how is that relationship in trust? What are the people, is there a good open dialogue? Are they able to ask the questions? Can we help coach questions to ask at that healthcare appointment? And can we communicate also on the back end to help them with consistent messaging and working together as a team? So I think all those different relationships are things that we can start to help somebody navigate.
Can we dive into some of those and what that coaching would look like?
Sure. Yeah. So I think sometimes starting with some of the individual themselves, they're going to have struggled to communicate if they don't understand about what they're going through. So I think the first step is education, and that could start with educating yourself if this is something that is new for you to be thinking about more deeply. But then that's great, because you'll be understanding it from your perspective, which may or may not be a biomedical perspective. And then that language and how you understand things can be very applicable to the individual that you're working with. Some key things that I like to focus on is things about the biopsychosocial model, how all the different factors can be going into a headache, and about maybe there's a model called the accumulative stress load model, where it's things about that sometimes we have particular triggers, but sometimes it's the accumulation of triggers that kind of precipitates pain, and how sometimes it is just random, even if we're doing everything perfectly. It is kind of a chronic condition for some people. So sometimes understanding that that it's there and it's real, and that sometimes maybe it's partly related to stress, and maybe partly some of the time there's other things going on too. And so that piece of education can be very real, and then helping them connect it to their daily lives and their functioning. So understanding, okay, and being able to articulate, when I have a headache, it's difficult for me to concentrate, or difficult for me to be up and moving or doing my sports, or sitting at a desk or talking with people, or going to a movie theater with bright lights, and just kind of starting to appreciate what is challenging and connecting the pain to the function. In terms of some of the nitty-gritty with the healthcare provider, being able to go into a session or an appointment, knowing that sometimes they're very brief. And I think coming up with a key list of questions that are important to be answered. So maybe the most important question is they also want to hear from their healthcare provider, what's going on with me? Why do I have headache? Or why is this a headache and a migraine? Or why are you not recommending scans or imaging? Do you think I have a brain tumor? Those are great questions to make sure you get out there, because sometimes the physician may not appreciate that those are the questions that they're coming in with. Just, they don't read their minds either. And being able to come in and make the most of that brief time that they might have with somebody, or why are you recommending this medication and not this medication, or what side effects. Obviously they'll go over those, but making sure that they're being able to focus and ask the questions that they really want to know. So those might be some nuggets of things to think about when working with somebody who's maybe about to see a specialist for the first time maybe, or has an upcoming appointment, is kind of coaching around what are the most important questions to be asking.
Mm-hmm.
Next, with school and workplace, some things to think about is just helping the individual appreciate, how much do I want to share? How much do I not want to share? That might be especially more relevant in a workplace than with school. With a workplace, thinking about, okay, how much is this impacting my work directly? And is it worth bringing up something with HR? What kind of documentation might I need to bring to support a request for accommodations? And kind of, I think, empowering somebody by thinking through, well, what accommodations might help me that I think my company could reasonably offer, so that they're not putting the burden all on this HR representative who may not be in the healthcare field, may have done an undergraduate in psychology or something and moved on with their career, and being able to partner with them to empower them and saying, here's what I want to ask for, and here's some information about my diagnosis, so it's not just a headache.
Right. And that just a headache thing, that feels like maybe the hardest part of communicating with people is either fearing or knowing you will be met with that response of like, yeah, with that prevalence, like we all get headaches basically, like, welcome to the club. I'm still going to work. I'm still fully functioning. And that projection that somebody who does have headaches and is getting by just fine may have on somebody who has headaches but can't, like they just truly cannot function at the same level.
Yeah. I like to, when I'm working with an individual, kind of help them create a script that they share with other people, whether it is, friends or colleagues or people that are in positions of authority to which maybe you're asking for accommodations or things like that. And of course, preparing them that you're probably going to tailor it depending on who that person is and how much you want them to know or how close they are to you. But kind of having a starting place with a script, I think, alleviates a lot of that anxiety and also makes those communications and interactions go a lot better. So the portions of the script, and again, this ultimately only takes a couple of seconds to say, but it takes some forethought to prepare it, is a name of a diagnosis and a brief explanation. So they might say, I get migraine. That means it's a really intense migraine. It occurs at random, but sometimes up to a few times a week. And it means that I can barely even sit up without my head absolutely pounding, or it means that the bright lights of my screen are really painful to me, or it means that my vision is even clouded or something like that. Just a name and a brief explanation of what they're actually going through to help somebody appreciate that this may be somewhat similar or maybe different than a personal experience, or something that they're expecting. And then the next portion of it is, again, a sentence or two customized what a person is comfortable with disclosing, but something, a little bit about their treatment or what they're doing about it or what they're requesting for. So for instance, that means that, I take medications and I keep a strict routine, and that, I always try to persevere, but I may need additional absences or additional PTO or flex time or something like that, or school-based accommodations. And so, or I might need to miss something sometimes. So kind of a little bit of a combination of things where we're, again, naming the diagnosis if you feel comfortable, a little bit of a brief explanation about what you actually experience. Because again, people come in with a lot of expectations. So sometimes I've never heard of that kind of thing. And then a brief explanation of what you're kind of already doing about it and or what the ask is.
Mm-hmm. Are headaches or migraine protected via FMLA or ADA, or is there any sort of legal protection for keeping your job if you do need accommodations?
Yeah. I mean, FMLA could be used, especially if you're a parent caring for a child who may be hospitalized or something like that. And you should be able to get workplace accommodations. Sometimes those are a little harder to come by, depends on the size of your business and things like that. But certainly in schools, students who are enrolled in public schools have the opportunity and the right to pursue something called a Section 504 plan,
Mhm.
which is kind of like an IEP, which some of you may be familiar with, an individualized education plan. The way I like to break it down for families is an IEP is often providing services within that education plan. These are not exclusive categories, but that's often the case. And a Section 504 plan is more focused on providing just the accommodations, how to
Mhm.
kind of level that playing field in a way. So there's a number of things that a parent in a school might put in a plan, depending on their child's needs, to set them up for success, provide some accommodations, and it's under the idea of other health impairment categories. So this is not a learning disorder, or something like that, but it's an other health impairment that is built into the law, and they should under IDEA, and they should be able to get accommodations. Even if your student is in a private school, they often have similar plans, but sometimes just less protections. But what that does is it means that the school is on board with, and once it's kind of signed, there's legal protection in place. That is the plan, and all teachers of a student should be complying with it.
Mhm. I really hope everybody who works with kids or works with adults who have kids who may have headaches or migraines, like really heard that. So back it up and listen to it again if you need to. But I think knowing that there are accommodations out there for kids can make life so much easier for those parents.
Absolutely.
Um,
I think it takes
yeah.
the stress off of, should I push them to go to school today? Should I not?
Mm-hmm.
And sometimes even alleviates the stress for the child, sometimes knowing, oh, like I'm scared to go to school today because my head is really hurting, but I know of a place to go if I need to take a break or a rest, or I know that I'm going to get notes from my teacher after. So all I have to do is sit and listen. I don't even really have to like focus on taking notes. Or if I do miss, I'm not expected to have all the work ready the day I get back to school,
Mm-hmm.
because that would be really stressful and may lead to more absences.
Right, right. And so you'd mentioned with like FMLA, if your kid's in the hospital, but would you be covered for time away if your kid just was home from school? Does the bar not high enough? Like, is the bar too low there or too high rather?
That's a great question. I have not coached as many families around that, and I know some families have, more flexible hybrid positions now that have made such accommodations. And usually, when I'm working with children, I'm really trying to help them avoid more of those absences than necessary. So that's
Right.
ultimately not the goal, is to be kind of stuck in that position.
Mhm.
But I have helped some families, document things, especially when it comes to appointments and things like that, or hospitalizations or treatment, to document that the parents need for time off. So if somebody's coming to see me and they bring in some FMLA paperwork for the time that they had to take off to drive their kid into my office, or pick them up from school to do a virtual session, we can document some of those things at least. So that much I can say. Mhm.
Got it. Okay, wonderful. I'm thinking about another category you mentioned in communication was like partners and kids, if you're the one who has it. And just thinking, as a mom, there's just so much work that goes
Mhm.
into like having a household, that in an ideal world is shared evenly across partners. And how when one partner does have to pick up the other person's work because they're sick, it can be very difficult. Like it, it's fair that the person who has headaches or migraines gets to take care of themselves, and it's also fair for the person who's doing more work to feel some frustration around that. How do you help people communicate with their partners about their needs and the family's needs as well?
Absolutely. I think you're right. I think we all kind of come in with the expectation around things like, oh, if somebody's has the flu or other illnesses,
Mm-hmm.
then, of course I'll step in and step out, and I would never make you feel bad for it. But when it's something that becomes chronic and it's recurring frequently, or B, it's something that we kind of feel like we understand ourselves, and we're like, I push through a day with a headache, that can compound maybe even just tiny lingering feelings of frustration on behalf of the partner who is picking up the slack. And then the person themselves, like you said, a lot of us hold expectations for ourselves and are doing a lot. And we may feel a lot of guilt around taking time off. And then that doesn't really feel like the self-care that we're supposed to be doing. So it can really become this vicious thing where everybody's mad at themselves and kind of the other person for their perceived communication. So a few things that I would suggest is please don't get into an argument and get into it in the middle of the experience, right? So if we're in the middle of a migraine, not the best time to like start thinking about a long-term strategy or approach. Some things that might be helpful is to kind of have an action plan, to just kind of talk it out when you can have a moment of calm and think about, okay, when I am experiencing this, maybe there's different levels and we do different things. So if I just have a headache or, it's not that bad, I'm going to take a 20-minute break and I really need that 20 minutes, but that will allow me most of the time to get back to things. Or if it's a really bad day, I need to take my abortive medication, it's going to put me to sleep. This is what I need, and try to partner together and realize that hopefully they're in it together in a way, and recognizing that there's a lot of different things that we all do to support one another that maybe are sometimes visible and maybe not. And if somebody is genuinely feeling like they're doing more than they used to or more than before, it's a good time to revisit how we can support each other in all different kinds of ways. And then I think another thing is if there are children in the home, recognizing that you're being a role model in a lot of ways. And it doesn't always mean pushing through and pretending something isn't there. I mean, I think that resilience and saying, hey, mom has a headache today, let's be quiet and let's show, like, that's how we're going to show kindness to each other, is by being a little quiet for a little bit. And then we can all feel better and play. And modeling those positive adaptive coping, and saying, and I'm going to take care and then I'm going to get better and we're going to continue going on, and things like that. So, whatever's relevant, it's hard for me to extrapolate what might be relevant for each particular circumstance. But I think remembering that this is an opportunity, as well as a burden. So hopefully there can be a double side to that.
Yeah, absolutely. Can we talk about like tools that we have to deal with, manage, experience pain? Either the tools we already have or the tools we can gain. It can be helpful.
As clinicians, yes. I think many therapists kind of get mystified when it comes to something that sounds medical, like headache or migraine. And again, especially if it's something you experience and you struggle with, it could feel like, well, what am I supposed to do to try to help? But I encourage people to just kind of take stock of your kind of therapist toolkit and realize that a lot of what you have to offer that can be modified pretty simply and used to help somebody. So thinking about what an individual might be struggling with, is it knowledge? You can read up on things and learn things and help somebody distill it down and explain it in a way that matches their needs in visual and creative kind of ways. Do they need help communicating with somebody? That's something that you maybe don't know exactly what to help them communicate with, but you know how to help people communicate, and kind of learning from their experience and saying, okay, now I know, that these are common communication tools that I use in other kinds of areas that I can use with somebody. Motivational interviewing is sometimes a huge thing that can help with any kind of behavior change. So if somebody's trying to get on a better sleep schedule because their doctor recommended it, but they're really struggling, can you maybe start with some motivational interviewing and some sleep hygiene that you know about from other diagnoses that you help the individuals with, or conditions that you help people with. Relaxation training, cognitive reframing to develop more adaptive thought patterns to cope with the stress and burden or the avoidance that maybe comes up with headaches or different kinds of pain disorders, are things that a lot of people with broad training in things like CBT or other similar approaches are things that you probably do to help with people with other kinds of diagnoses. And then finally, also recognizing that when somebody's coming to you with headache, they're also probably coming to you with other things too, like maybe they're stressed, or maybe they're upset. Maybe it's about the headache, or maybe it's about other parts of life. And those same techniques that you were thinking of using for those other conditions like anxiety or depression or trauma are going to have a ripple effect. We're all interconnected. These diagnoses are not completely separate. They're all with, we all have these interconnected experiences. And so the things that you were probably thinking of helping will probably have a ripple effect. That being said, the things that you might want to educate yourself on are the core components of different recommended treatments for headache and migraine. So one of the best studied ones is CBT, but there's certainly a lot out there with ACT, pain reprocessing, other kinds of approaches that have been adapted or developed for helping with pain or pain conditions. So you might read up on those or how they've adapted techniques that you already know how to use. Or what are the actual behaviors that I might want to help somebody do? What are the kind of actual ones that have the best evidence to help somebody? Or, what kinds of relaxation techniques might be most useful for this individual? Or let me read up about the experience of people with headache and migraine, so I can anticipate what kind of symptoms, functioning challenges they might be experiencing.
Are there, and I know we'll have some listed, but are there good places to start in finding reliable evidence? Because we're going to talk about some myths in a second, but there's so much out there of like, if you breathe too close to your cell phone, you're going to have headaches and brain cancer. So how do people find what's reliable?
That's a great question. I would start with peer-reviewed research if you wanted to just get down to it and read it from the actual original source, because everything that's going to be secondhand will have a slant or a lean to it. But another great area that is a little bit more approachable might be the American Migraine Foundation. They have a lot of great resources for clinicians and for individuals and families. They have some infographics and articles that will walk you through a little bit about what is headache and migraine, some of the triggers and factors, and things about workplace accommodations or lifestyle things that might be good places to start, just getting a sense of where things are.
Yeah. Are there, no, I'm not going to ask that question. I was going to ask you if there were some places not to look, like specific places that are maybe disreputable. But we don't need to necessarily do that. What are some headache hygiene or lifestyle changes that we can specifically share within therapy, within our scope, that can help people manage the pain when they're having a headache and kind of strategize, like you were talking about, with family, with work, with all those things in order to make it less bad when it's going on?
Yeah, that's a great question. And this is definitely not an exclusive list, but I think the 4 top areas that have been promoted in the literature and that individuals anecdotally seem to experience benefit from are sleep, hydration, nutrition, and physical activity. Those can all be difficult in their own ways. I think the most impact often people experiences with sleep and hydration seem to be 2 really big ones with really good backups for impact and outcomes with behavior change in those areas, but certainly other factors with diet and physical activity. And usually I present to some of those areas. I highlight what I'm seeing. Oh, this is what you're doing already really well. These are areas that we could optimize, and let somebody collaborate with me. Hey, where do we want to start? So although there may be more impactful ways that we think somebody should start, it's really about what they're ready to start addressing. And so with sleep, we're looking not just how long somebody's sleeping, and most people underestimate how much they're actually sleeping. And most people also underestimate their actual developmental needs. So sometimes starting with a sleep log, because our memory can be like, oh yeah, I get it 8 hours a night. And then you look back actually the last week and maybe you got closer to 6 or 7 most nights. So those can be a good place to start, but we also care about the quality of that sleep as well as the consistency. Is it all over the map in terms of what hours we're going to bed and waking up, or is it relatively stable? So those are the qualities of sleep that I'm looking for and trying to optimize. Hydration. Okay.
Before we move to hydration, I'm curious, like I have an Aura ring. It gives me all my sleep data every morning. I love it. I know how much deep sleep I got, like all these various things. For people who don't have a tool like that, when you're looking at like the quality of their sleep, how are you measuring that, or how are they explaining that to you so you can assess it?
Sure. I think some of the at least things that I start to ask about is how long did it take you to fall asleep? And do you at least remember waking up in the middle of the night? The nice thing about those wearable technologies like the Oura Ring or Fitbits or Apple Watches is they're going to be tracking more data related to movement. And so they might be able to tell, if you had some restless sleep that maybe you were not cognizant of overnight, or you don't remember in the morning because you weren't fully forming those memories.
And then if they are, let's say they're having restless sleep, and then that next day they end up having a headache, like, are you making that correlation? And then how are you helping them have less restless sleep?
Yeah. So sometimes, I mean, again, important to check in with a healthcare provider because sometimes things like restless leg syndrome are triggered by iron deficiency. So that's a simple blood test, and some examination and history taking could reveal that. But if somebody is waking up a lot in the middle of the night or having trouble falling asleep, then that's a time to bust out some sleep hygiene techniques, and again, work with somebody to try to see, can we start to implement these? And then maybe not immediately, but over time, maybe we notice that we're having less headaches, or that we become a little bit resilient to impact on our sleep. And so the kind of techniques we pick might be a little bit different depending on if it's something where I'm waking up in the middle of the night and I can't fall back asleep again, or is it something where I'm having trouble settling down in the first place?
Got it. Okay,
Yeah,
great.
but sometimes tracking things and learning about those patterns, especially if somebody is not sure if it's something that they want to change or doesn't feel like they maybe can make a change. Sometimes just starting with just tracking. So logging your sleep, and if you don't have something like a wearable, just as soon as you wake up in the morning, put down when you went to sleep the night before, what time is it that you're waking up, and any memory that you have about if it was hard to fall asleep, or were you waking up in the middle of the night? Your memory is going to be freshest at that point. And just seeing, and then tracking maybe the headache frequency, if that's the outcome of interest, or just how tired you are, or things like that, and just starting to make those connections. And if there is something there, then maybe there's something to more specific and focused to work on, as opposed to some of these like broad lists of things that we all know we're supposed to do, but
Right.
don't need to say more about that.
Right. Okay, great. So let's talk about hydration. What are you looking for there?
Sure. So obviously, I think you may have seen different headlines. Oh, it is 8 cups of water, or it's not 8 cups of water. Sometimes a physician may be able to provide a weight-based recommendation of water intake, but it's so different person to person, based on our activity levels, our sizes, what we're used to. But some things to look out for is if I'm only drinking when I'm thirsty, that's probably a sign that you're dehydrated. And we also say to try to drink as best as we can consistently through the day, as opposed to trying to chug it all right before we go to sleep at night, or something like that. And so, usually if somebody is maybe drinking way less than their recommendation, maybe we either start with that big goal, or maybe we just add in a little bit at a time and see if and when we start to feel better. And so sometimes and that's sufficient, or sometimes we need to maybe also address the sleep too. And it's kind of those combined effects that can be helpful. But hydration can be huge if somebody is dehydrated. It may not take care of all their headaches, but it could be a big portion.
I wonder, you've worked so much with kids and have so much experience with them. My personal experience with human beings is that kids are less, right? Yeah, I've got mine right here. Kids are less excited about staying hydrated and maybe dislike water more and things like that than most adults I know. How do you get them drinking?
Yeah, great question. I definitely don't have the magic bullet, but I will say trendy water bottles have kind of been a nice thing for improving interest in hydration. So although I don't have one myself, it's kind of that if the fact that water bottles are the new it thing, I'm not mad about it.
Right.
But I think, it's about figuring out what the actual barriers are. What is actually getting in the way? Is it that I don't use the bathroom at school? Is it that, I always forget my water bottle in my locker? Is it that I don't like the taste of it? Or maybe my water bottle isn't the best. It's like always spilling and loose on me. Or is it the fact that my mom's just snacking me and I just don't like that part of things? Kind of figuring out what it is, or I just forget. I just don't remember. It's not on my mind. kind of figuring out what the sticking point is and then going from there and kind of saying, okay, are you willing to think about something? Hey, you know what? This is something that we can try, and kind of doing that motivational interviewing to see if they're even open to making a change, and then focusing the strategies on their actual barrier rather than just saying, oh, you should just use the water bottle with the numbers on it. I mean, that might be the right strategy for them, but it might not be addressing their main issue.
Mm-hmm. Yeah.
If they're a teenager, get them away from their parents, and see if they're often a lot more willing to consider making a change in some of these health related areas, when it's their own, perceived as their own decision.
Mm-hmm. I'm thinking about how I think we talked in the pain conversation about my daughter has migraines,
Mm-hmm.
and thinking about how the way my brain works is I can avoid this awful outcome if I do this thing. And so I will
Yeah.
do the thing because it is very clean and simple to me and my most logical self.
Mhm.
But that doesn't work for most people. Um, is there a way to encourage that and to continue to make that correlation in a way that's not shaming of like, well, if you
Yeah.
just drink your water, you wouldn't be having this, like I don't want to come at it like that. How would you guide parents, or even like your own self-talk if you need this? How would you guide that?
Yeah, I think, well, it starts before we start talking about hydration. So before I start talking about hydration, we're talking about how headaches and migraines are complicated and that there's lots of factors that go in, and some of them are in our control and some of them aren't. But even the ones that are in our control, they can feel unrealistic or unsustainable, and they're maybe not as exciting or fun to do. And then we look at the people around us and they don't seem to have to care about hydrating or sleeping well, and they're feeling fine. And just acknowledging that, but then saying, okay, can we find small ways to improve this in a way that feels sustainable, in a way that feels authentic and fits in your lifestyle, and see if it's worth continuing on with.
Mm-hmm.
And view every change that we make as a little bit of an experiment. Let's try it for a week or two and then see what happens. But you're right, also for many of us adults, but definitely, younger kids, that long-term reward of being rewarded with less headaches or that removal of that aversive outcome may not be quite enough to make a change today.
Mm-hmm.
And I think you're right, kind of building it in as a positive. So a couple of things come to mind. First of all, if you are a parent and you're trying to get your child to do this, is the whole family hydrating? Or are you putting it on, you're the one who has to hydrate, the rest of us can think about whatever. So
Mm-hmm.
whether it's sleep or activity or hydration, kind of not punishing somebody by making it a whole, this is something we all do to be healthy, and it might be extra helpful for you too.
Mm-hmm.
So let's
Yeah.
see what we support it and make it not feel like, oh, they have to go do their laps around the block and we're sitting at home watching TV or something like that, or
Right.
everybody else has Coke and you get your water. So that's one of the first things that comes to mind. But certainly there is a role and a time for sticker charts and rewards, especially when something doesn't feel as motivating in the first place. And that's something you can do for yourself as an adult.
Yep.
And you can decide, how often you reward yourself or what the outcome is that you have to do to achieve it. Things like that. And that's something I partner with people to figure out what's the right way to frame that for themselves.
Mm-hmm.
And then there are a couple cute apps out there that are motivating because they kind of keep track of things and you can kind of see your progress. And if it's something that if your phone is something, that you're already using, then why not leverage your techniques or tools that you already have?
Yeah, absolutely. So let's talk about nutrition. I'm guessing this is also where a lot of the myths may come in.
Mm-hmm.
So we can also weave in myths through this, if that makes sense, or we can talk about myths after.
Yeah. So I always caution individuals, and I would encourage therapists to caution anybody they're working with. We are not dietitians, unless you are also a dietitian, in which case, amazing, wonderful. That sounds like an amazing combination of skills. But if you're not a dietitian, we cannot prescribe diets, but we can work with dietitians, physicians who are making recommendations to help people make those lifestyle changes. And or if somebody comes to you and says, hey, I think it would be helpful if I worked on eating this way but I'm struggling, you can definitely help them too.
Mhm.
But some things I might I might suggest for somebody are to be thinking about, are we skipping meals? So that could be a trigger for headache or migraine, is the kind of fluctuations in fuel or energy that your body is giving. So if a person or child is telling me like, oh, I just don't like eating in the morning and I don't eat till like lunch until like 1 or 2 o'clock. And then I eat a big dinner right before I go to bed at night. Those might be things to consider experimenting with and seeing if maybe spreading out that, even eating something tiny in the morning, if that might be something that could be helpful for them.
Mhm.
I think the myths start to come in when people really want to kind of find a food trigger. And that is definitely true in a small portion of the population, that certain foods are particular triggers. And I feel like it's an attractive idea because it feels like something very much in our control. If I
Yeah.
just don't eat that thing, then I'll feel better. So we search and search and search, and we keep all these diet logs to try to find that magic thing that if I just didn't eat it, I would be okay.
Mhm.
But thinking about the likelihood that that is the case for you, and first of all that time and intensive work to consider everything that you're eating and trying to track that temporally, with a headache can be tricky and also difficult to know, like how far in advance would I have had to have eaten it to count as a trigger. But
Mhm.
then certainly I feel like we've talked about the impact of headache and migraine, and that's already enough. I would really hate for somebody to feel like they had to give up a huge food group, things like dairy or gluten or sugar, um, it may not be necessary. So I encourage them, if they are starting to notice these temporal or chronological patterns, like, oh, okay, when I do eat, this kind of a meal or these foods, I am feeling worse, then maybe start to log that, or maybe talk with a specialist who understands food and diet, or can help you go through the proper tests to determine if it is something you should try eliminating or trying modifying. Um, but if it's not something that you've even really detected for yourself, then I think there's these other categories that we know have some strong evidence that they can help. So maybe let's start there.
Mhm. Got it. And then what about physical activity?
Yes, that's a tricky one with headache and migraine, especially because
Mhm.
one of the criteria for migraine, that is one of the some of the main things that um, are kind of almost definitional of migraine, is that sometimes exercise provokes or exacerbates
Mm.
pain once it's already there. So physical activity can be a tricky one because on the one hand, it can make things worse. On the other hand, long term and being active can actually be a prevention in some ways.
Mhm.
So this may be complicated and may end up requiring some help from a physical therapist, maybe such as a cervical physical therapist. But if it's not something that's happening every day, like every time I get up and walk, it's starting to hurt, or I completely cannot do my sport every day because every time I try, I'm immediately knocked out with a migraine. Outside of those things, there's things that a therapist might be able to help encourage, that might be able to help. So if somebody's kind of starting with not being able to do any activity, can we help guide them in taking some baby steps to literally maybe take some baby steps of outside, or on a treadmill if it's icy like it is here in Michigan today.
Mhm.
Or some gentle stretching or yoga, and seeing if some of those things start to help. And then building progressively up from there. If they're particularly sensitive, we might really stick with some of those things that don't involve a lot of head movement. But I really kind of let them be the guide and pick things that they're kind of already interested in trying, and going from there, rather than prescribing, oh, you should do yoga when they're like, I hate yoga. Well, then that's probably not going to happen.
Right. Right.
So I think what I'm trying to say is that we're trying to promote a stable level of activity, um, maybe a little bit of mild to moderate cardiovascular, has some evidence to support that can play a prevention role in headache or migraine. And sometimes people actually say getting moving actually makes them feel better.
Mhm.
And then sometimes that kind of having that baseline of activity can actually make the fluctuations in activity. So then I go for a jog, or I'm playing my game of basketball, maybe because I have this foundational layer of physical activity and physical fitness, that sudden change doesn't provoke the sudden change in heart rate that going from being completely sedentary to moving around does, or whatever other mechanism might be in place, to be a little bit more resilient to those changes because you don't have as much discrepancy. So that's something that might factor in.
Got it. And I think about like the activity one feels very, there is no difference between the mind and the body, right? Like we think about how helpful activity is for our stress levels. We think about how helpful activity is for most of our systems in our body, and how it makes sense that that is an important and helpful option. I think like as we speak, I have had a headache since yesterday because I overdid it at the gym, and was lifting a weight too heavy for me. And as a result, the wrong muscles got involved, right?
Yes.
And so I've got like a tension headache from those muscles trying to help support this thing that I shouldn't have been doing. So, you know, it's a balance.
Okay.
Yeah.
Exactly. Yep. A lot of people with headache kind of tell us that they have a lot of that tension in their shoulders and their neck. And sometimes it goes both ways. Like you said, sometimes we are tense, and either it's because we overdo our lifts at the gym, or because we're sitting with a lot of tension, and then that can trigger that cascade upwards with a headache. Or sometimes it's a posture that we take kind of to compensate for the experience of pain in our head. We kind of naturally tense up, or it could be a symptom of the headache or migraine itself. For some people, that causes neck pain as well. So it kind of goes in a little bit of tricky both ways.
Absolutely. And I also know if I take a walk, it'll feel better, right? Like, so it's messy. And thinking about like the fluidity of that for our clients, that, you know, they might be like, well, I tried that and it didn't work. And to help them maybe try different or new or again, or something like that with each of these, with sleep hygiene, hydration, nutrition, activity, like all four. Do you usually start with just one, or do you try to, like,
Yep, that was a simple one. Yes, I
the answer is yes.
Yeah. I typically encourage, even when they're coming in with a lot of enthusiasm, like, yes, I'm ready to do all the things. I say, I love this enthusiasm. I love this energy, but let's think about what the energy is going to be like when you go home and you have all the different usual demands on you. So you may be excited in our office or on our video today. I appreciate that, and I would love you to take it with you. But let's at least maybe prioritize one area. And then if you're feeling ambitious, here's one or two other things you can do that day. But I think we see the most success when we kind of narrow down the scope of our goals and do it in a progressive way. So let's start with one area and then layer on, with the caveat that sometimes it does take a few things working together. So just because improving our sleep didn't change everything doesn't mean we should abandon our good sleep practices and then start, hydrating or something like that. So it's a little bit of a caveat, and sometimes the things do complement and augment the benefits of one another.
Absolutely. Are there any other myths that we should be cognizant of going into these sessions with clients?
Let's see. I think we covered a couple of the big ones. The kind of misconception around food triggers. Again, it does happen for some people. It's just not as common as most people think. And the fact that migraine is not just a bad headache, but being sensitive and going with the flow. If somebody uses particular language to describe their experience, we're not here to shame them, be like, you're wrong. Maybe providing that education, like, hey, you know what, when your doctor talks to you about your headache or migraine, they might mean something a little different than you might be trying to convey. And has that ever caused any troubles for you? So that might be an area to kind of help somebody navigate, but also maybe more impactfully people in their lives to be able to understand. I think those are kind of the two big ones that come to mind, but I've been in this field for a long time. So I think sometimes the myths are obvious for me.
Right.
Yeah. I think sometimes one of the things that we as therapists should be sensitive to is that tension type headache oh, it's just stress, and it just gets kind of turfed over exactly to us. And I'm excited about that because I'm excited that people appreciate the role of what we can offer to help. At the same time, I want to validate the experience and that the truth that it is always both, right? It is always a biological and an emotional, psychological experience. It's really hard to completely disentangle one or the both of them. And so sometimes it does mean there's more of a role of one of those approaches to take in treatment. But I always joke that it's not all in your head. I mean, it is all in your head when it's a headache or a migraine, for the most part. But either way, it's not all in somebody's head just because they're seeing a clinician, a therapist, or a psychologist to help.
Right. Awesome. Thank you so much for teaching us about this. I'm really grateful. And I feel like as a clinician, I'm able to have a deeper conversation with my clients when they're struggling with headaches or migraine. Much better questions to ask them than I had before. So thank you.
Thank you for this opportunity.
I hope that broadened your clinical horizons. Head over to notboringces.com to get your CE credit. Want to have a not boring conversation with me about your clinical area of expertise? You can apply there too. If you like this conversation, leave us a 5-star review, tell a friend, and be sure to subscribe for future conversations.